Welcome to this week's Merit Update. It's Thursday the 9th of April, and as you know, we've been trying a new way of getting information out to you. There's been a lot of feedback, a lot of learning points that have come back through the QR codes on the LocSSIPs and communications with Sam, Hannah, Juma and yourself. So we're hoping to disseminate some of that information in a different way rather than having to go through all your emails, because there are a lot of them at the moment. I'm Andrew Hughes, one of the consultant anaesthetists here at the Glenfield, and I'm here with Rahul Mandalia, one of the ST7 registrars who's working on ITU. So there's quite a bit to get through. Let's start with logistics. What can you tell us about some of the logistical issues that we've been having with these patients?
So two main things, Andrew, that have come to light. I think the first thing is certainly that anaesthetists are finding it very useful to intubate and insert lines in theatre. It's just a generally more controlled environment, familiar environment. The second thing to be mindful of really is transferring these patients from the ward to theatre to do that. So when patients are on 15 litres of oxygen through a non-rebreathe bag, that's fine, they can be transferred on that. But just be mindful that some patients who are on CPAP or NIV may not be able to tolerate a transfer on just 15 litres of oxygen.
We certainly shouldn't be transferring them with CPAP or NIV running. I think it's fairly standard now. A lot of the teams are finding that when they go out to get the patients, it's really worth having your transducers, your lines and all your kit set up in the anaesthetic room, so that when you arrive it really speeds up that process. And also donning all your PPE in theatre helps just smooth that process of picking them up and retrieving them.
Yeah.
Walkie-talkies, some changes from last week. What's that?
The change last week was that we are on channel 8,
right.
And we are finding the walkie-talkies really useful.
Yeah, we've got 2 on each Merit team. That'll be for the in the hot zone and the runner that's outside, and ICU also have one that's on the same channel, should we need to communicate with them. Patients, identifying them, really quite important, because we've got a lot of people coming through now, so what's the sort of deal there?
So one thing that we've certainly learned on the unit is when you see patients, on the ward, they don't necessarily look that well. Obviously they're on a lot of oxygen and their EWS may show that they are worsening, but actually when you go to see them, they may be speaking to you, look relatively comfortable, they don't look like they're in extremis. So as you would do with anyone really when you're going to retrieve patients, do a 3-point check, so name, date of birth, test number.
A couple of the patients I've attended, I've just wondered whether I've got the right patient, because they don't quite look how you expect them to. Filters now, we talked about them last week. We have the yellow viral filters and we also have the green HMEs, but a bit more advice about what we're doing with them. What can you tell us about that?
So our guidance has changed slightly courtesy of Dr. Shupp recently. So our viral filters, which are the yellow filters, they protect the ventilator and they should be placed on the expiratory limb on the ventilator.
Right.
The green HMEs, which we are familiar with in theatre, they protect the patient's respiratory mucosa and should be placed at the patient end.
Right. Breathing circuits, particularly on the anaesthetic machines, we don't really need to change them as often as we think. Is that right?
No. So if there's a viral filter connected to the expiratory limb of the circle, then it only needs changing once a week.
Endotracheal tubes, is it concerned over the length of them? Is that right?
Yeah. So it's more sort of a suctioning and nursing issue really, in that the suction catheter it may not be long enough to overcome the length of the ET tubes if they're not cut.
Great, okay. And just one other thing actually that just comes to mind is a lot of people are finding the clamps are quite aggressive on these tubes, real risk of damaging or splitting these. We could be using a bit of gauze just to protect the tube from the harsh edges of the metal, so that's something worth considering as well. NG tubes, so a few points here. Essentially they're really tricky to put in after the patient's on the unit, the paralysis is worn off, so we really do need to be trying to get those NG tubes in at the time of intubation. Is that right?
Yeah, exactly. I mean, I really appreciate that NG tubes are difficult to insert at the best of times, and we know in theatre it's not always easy either. But it really does save a lot of time and effort if they're put in at the time of intubation. As
well as the NG tubes, the central lines, intubations, really important to fill out the LocSSIPs and hand over all the information that's important.
And often it's because perhaps the other side of the page isn't completed. It's really important to know things like laryngoscopy grade, adjuncts used for intubation, drugs used, because if we're extubating these guys a few days or even weeks down the line, we need to know that information.
Okay. Right, so just going to update you a little bit about CPR. There's been a bit of confusion in the last week or so about whether CPR counts as an aerosolizing procedure. Now, a lot of us would naturally think that chest compressions and defibrillation are aerosolizing procedures, but and that's indeed what the Resus Council UK had suggested. But actually, the World Health Organization hadn't had it as one of their aerosolizing procedures. So this week, in fact yesterday, there was a bit more clarity. Defibrillation and chest compressions are not considered aerosolizing procedures. However, the stuff that we do in critical care, anaesthetics, on the MERIT team, we're attending in an airway support capacity. So the things that we are doing that are aerosolizing procedures are suctioning the airway, intubating, and other airway manoeuvres. So if you are going to a cardiac arrest, then we need to be wearing full FFP3 face mask, visor or equivalent, and the appropriate PPE. Finally, need to bring your attention to the wellbeing areas. We have a number of areas now that have been set up, and they've got a good stock of food and other items, so do check them out. There is an email coming out tomorrow detailing a lot of the information that hopefully you'll find useful, how to access these areas and what's available. We want everyone to be as well supported as possible because it's a difficult few weeks and months, so we've got to look out for each other. So that is pretty much it for this week's feedback. Thank you, Rahil, for joining me. Do keep your emails and your feedback coming through on the QR codes or directly to myself, Rahil, or Sam Hanajuma. There's still a lot of learning, a lot of experience being built up in what is a fast-changing situation. So thank you very much. And in the meantime, just stay safe and see you next week.